Hi, I'm Dr. Jared Gardner. I'm here today with my awesome dermatology residents, and let me move that out of the way. And we're going to talk about malignant epidermal lesions and also some mimics and stuff of that sort. So this case you guys have not seen since the virtual slide for this one was messed up, but I'm going to give you a look here. This is one that I have from my teaching files. Well, tell me from this power, I know it's scarier when you haven't previewed it, but tell me what possible things would you think of here? Oh, there's a bit of dust. It's okay to be wrong, don't worry. No one dies if you're wrong here.
Like AK versus Bowen's.
Yeah, good, right. It's an epidermal thickened and it's got some jumbled, disorganized look and some increased keratin on top. So as we go closer, and this is actually like one of the most, I mean, this is something I see regularly, but it's such a perfect example. Look at that. This is Bowen's disease, right? Squamous cell carcinoma in situ. And this is a perfect example of kind of the pagetoid form, or I suppose you could also say that it's kind of got a clonal effect, right? From low power, I would also really think of a clonal seborrheic keratosis in my differential, because those can be kind of thin acanthotic lesions that are thin and broad sometimes, and they can have these round nodules of uniform keratinocytes. But as we go closer here, these are like gray cytoplasm, and in fact quite vacuolated, which we'll talk about in a second. And more atypical. And if you go hunting around, you'll find more atypia, mitotic activity. Sometimes if I struggle with these, I mean, this one's not a struggle, but if I have cases where I struggle between, say, clonal seb and squamous situ / Bowen's disease, sometimes doing like Key 67 or MIB1 and P53 can be helpful. It'll show a lot of expression way up. Although I don't do that very often. It's just occasionally I've had times where there's like large, like a large pigmented patch on the face, and I'm between, is this just a big, huge seb or a squamous situ? That's going to actually significantly change management, right? So in those cases, sometimes I've done that. Now, what do we do with all these vacuoles? Look, these are clear vacuoles indenting and scalloping the nucleus. I've taught you guys before, I think, that when you see clear vacuoles that push into the nucleus, that means they're lipid vacuoles. Well, a malignant a carcinoma with lipid vacuoles, we always teach is sebaceous carcinoma. So should I call this sebaceous carcinoma in situ? Well, those things have been published in the literature before, but I see this like multiple times per week, probably. Focal vacuole and sometimes extensive vacuoles in squamous situ. So it's hard for me to believe that these are all just happen to be incidental sebaceous carcinoma in situ, and clearly they, at least from, I've not gotten follow-up saying, oh wow, these behaved super aggressively. So whatever this phenomenon is, it doesn't seem to make a difference for the patient as far as patient care goes, from my experience. And my colleague, Dr. Junkins Hopkins, is particularly interested in the Bowen's form of squamous situ. And Bowen's is, I usually just call all of these squamous cell carcinoma in situ, but Bowen's, I think, is kind of used for the ones, the squamous situs that have like the full thickness, significant atypia, or this kind of clonal look. And in any case, she has mentioned, I think they presented at the American Society of Dermatopathology last year with Victoria Kozlowskaya from UPMC, that you can have a variety of adnexal differentiation in Bowen's disease, sometimes sweat duct formation, sometimes vacuolation like this that may be sebaceous or something. So it seems that the Bowen's form of squam in situ, which occasionally also can invade, can kind of mimic or have overlap with adnexal carcinoma. All right, the other thing I'm going to point out is this is like, honestly, probably the best example I would say that I have of eyeliner sign, right? When squamous cell carcinoma in situ spreads out beyond where it started, it tends to fill up, trickle, and have pagetoid cells in the epidermis and eventually fill up the epidermis, but it seems to spare the basal layer. Now, the way I think of it is where it starts, it kind of fills the entire epidermis, even the basal layer. But as it spreads out laterally, it fills up the epidermis but leaves that basal layer intact. And that's what you see there, is this like layer of basically normal keratinocytes, sometimes with pigment like here, underneath the base, and the carcinoma filling the epidermis up above it. So that is a pretty useful sign for squamous cell carcinoma in situ. You can see a little bit of eyeliner sign, although it tends to be thinner and more compressed in Paget's disease. And you do not usually see it in melanoma in situ. So that's kind of the trick there. So this is kind of an example of the clonal or pagetoid form of Bowen's type squamous cell carcinoma in situ. Oh, these are also, I believe, diffusely P16 positive. I learned from a colleague on Twitter, although I've never done that actually. So anyway, that's a kind of an interesting finding. Look at that. That's unbelievable.
Dr.
Wow.
Gardner,
Yes,
can
ma'am.
you throw Hidroacanthoma simplex into the differential from low power view?
Oh, absolutely. Thank you for bringing that up. Yeah, Hidroacanthoma simplex, which is kind of like intraepidermal poroma. Like it's basically that uniform monotonous cells just filling up the epidermis and not sending those fingers down into the dermis. And we'll see an example of one of those, not quite like this, but yeah, absolutely, Hidroacanthoma simplex could go in the differential. So the real thing here is deciding if this is malignant or not. And to me, based on the mitotic activity and the degree of atypia and just kind of the overall pattern, I think this looks malignant. And here's like, there's a couple mitoses there. Sometimes having lots of mites or high level mitoses can be helpful. But there's another one right there. But yeah, Hidroacanthoma simplex could certainly be in the differential here. Good point. All right. So squamous cell carcinoma in situ. Let's switch over to the digital slides here. All right, now this is case 2. What do you guys think? And you don't have to describe it. You can just tell me what you think it is, since I always seem to go over time. Where's this from? What's that?
Well, there's bone.
There's bone. Good.
And there's it looks like mucosal epidermis.
It kind of does, although it's a little bit of a trick. It is a specialized, unusual epidermis, but you're totally right that you could think absolutely of mucosa here because you have like the pale, kind of glycogenated keratinocytes, no granular layer. But this is actually under the nail. So the bone is the little tiny clue, but otherwise, if you didn't know where it was from, I mean, that absolutely looks like mucosa right there. Good point. And there's more bone here. So sometimes it's hard to know, is the bone actually normal bone or is it new metaplastic bone? This bone's got like some little lamellar bone lines, so I bet this is part of the normal bone of the finger underneath the nail. So they got really deep with this biopsy, man. So what would you think if you see this as a, mass that's kind of destroying the nail, and then underneath there's this?
Yeah, so like a KA or a subungual KA.
Yeah, right. So keratoacanthomas can occur in the nail bed. So subungual keratoacanthoma, of course, squamous cell carcinoma in the differential. And as you guys know, that usually in practice, I've been trained, and some other people agree with this and some disagree. But in any case, to me, it's very hard to tell a true keratoacanthoma that's going to regress on its own from a squamous cell carcinoma that's well differentiated and keratoacanthoma-like. I've got a whole video about that. This is an area of my view that's still evolving because I think it's complicated. And most of the time I just say squam Ka type, and if the dermatologist thinks that all keratoacanthomas are squams, then they're going to treat it. Others that think that you should manage keratoacanthoma differently and try more alternative therapeutic options, like I've heard that you can inject them with like methotrexate and that they respond well, or that you can watch and wait and see if they regress. Then other people will just disregard what I say. But these are the kinds of places where I do start thinking maybe there really is a role for like being cautious, because a squam invasive under the fingernail, there's a chance that person's going to get a partial amputation of their digit, right? So these are the kind of times that if something really looks like a keratoacanthoma, it may be worth trying some alternative rather than aggressive surgery. So again, this is an area that I still find very challenging. But for keratoacanthoma under the nail, you do get these like kind of cystic, these cysts that are filled with keratin. The keratinocytes are very pale and glassy, have abundant, dense pink cytoplasm, and there's not much in the way of nuclear atypia. If I start seeing really ugly atypical nuclei, then I start being much more concerned about true squamous cell carcinoma. But if I saw something like this, I would probably honestly be hedgy and say, well, I'm not totally sure, but this could be keratoacanthoma, especially because it's pretty rare to get a subungual biopsy where the entire lesion is intact and you can see the margins. I mean, that's usually what you get as a fragmented specimen like this because it's a very difficult place to remove something. So in any case, this was put in the study set. I don't know the history of this case, but as a subungual keratoacanthoma, and it is good to remember that they can occur at this unusual site, as can a variety of other tumors. All right.
So this one kind of an endophytic growth with some squamous eddies in there. So I was thinking like an inverted follicular keratosis.
Yeah, exactly. IFK, which has very closely overlapping features with irritated seborrheic keratosis, and some people think they're basically on a spectrum of the same thing. The key is recognizing these swirled little squamous eddies. They're round little balls of keratinocytes. Unlike horn pseudocysts, like in seborrheic keratosis, which have like loose keratin in the middle, these don't have anything in the middle, right? They're just a ball of keratinocytes swirled around. And they're different also from keratin pearls, which you see in the dermis in squamous cell carcinoma that's invasive, which is going to have little perikeratosis in the middle. So these are like the third little round keratin structure. I find people often get those confused. So yeah, irritated sebs can have them. If it bulges down like this, I usually would call it inverted follicular keratosis. And occasionally I've seen cases of tricholamoma that have overlapping features with IFK actually. So if it looks kind of warty on top and has some areas with some clear cell change and palisading, you could also think of tricholamoma. The key is benign versus benign versus benign, not squamous cell carcinoma. Sometimes they can get pretty irritated and inflamed and can be atypical, and I'll often see them shaved, like so broadly transected at the bottom. And in that case, if there's atypia, I'll usually say there's some atypia. I think it's reactive, but I can't see the bottom, and if it grows back, please remove it. Because I do feel like once you see this, it's pretty strong favoring of it being benign. I don't feel like I see these in real squamous cell carcinoma very often at all. So, but if I can't see the base and there's kind of inflamed stuff in atypia, then I am more cautious about it. So inverted follicular keratosis, benign and beautiful. Okay, the next one.
All right. So it looks like from here a squamous proliferation is kind of going down into the dermis. Definitely making keratin, and it's pretty heavily inflamed as well. So I'm worried about like an invasive squame. I know you can see heavy inflammation in patients who have CLL, or like the lymphoepithelioma like carcinoma, that can look kind of similar as well.
Yeah, so look, first let's talk about the squame. And again, I'm going to flip it. 1 second. One more. No, there's like it's like perfectly at the wrong angle. Look, this is why we hedge about stuff, okay? If you just had a shave of this, you could say it's a cyst. I mean, there's no atypia there. It's got a granule layer. It's loose keratin in the middle. And then over here, you could say, well, that's glassy. That could be keratoacanthoma. It's even got the little elastic fiber trapping, right? Well, what the heck's going on down here? It turns much, much uglier. I mean, honestly, to the point of, I would say that's, at least I would probably call this moderately differentiated in my book here. And you would start to even think, gosh, is it turning like spindled? And not quite, but I mean, it really looks ugly enough that I even would start to wonder if it's going to have an area of like poorly differentiated. So this is why I get a little cautious about calling stuff keratoacanthomas when I only see part of the lesion, especially because I've seen multiple cases like this that did not look bad at all at the top, and then down to the bottom got crazy ugly and real nasty looking, and you know, atypical mites and ugly, almost on the verge of spindling. So that worries me. But I like your point that you brought up here, that there's a lot of inflammation. And you know what's interesting is the inflammation is here, kind of around vessels away from the tumor too. So when you see a sheet of monotonous small round lymphocytes or a bunch of lymphocytes around, this is around nerves here, but or around vessels away from the tumor, always think about the possibility of chronic lymphocytic leukemia, small lymphocytic lymphoma, CLL, SLL, because it's relatively common in older folks, the people who get squames. People that have it badly begin to get immune suppression from the tumor, basically from the CLL. And I've seen cases where patients had numerous really aggressive squames because I think that it was because they had CLL. So basically, and I remember one, and I was going to pull it up to show you, but I forgot, so I'll have to do that later. But an example of really nasty CLL in the hand invading all the way down to tendons. And when they resected it, I saw sheets of lymphocytes, and I thought maybe it's CLL. And sure enough, when they checked the guy's blood, it was CLL. All his nodes and his marrow was involved. He had numerous metastatic lymph nodes with squamous cell carcinoma. And I remember talking to the surgeon, and he said, this guy has got like squames like a transplant patient would have. And I said, that's because basically his CLL is wiped out his immune system. And so he was having that same kind of phenomenon. So ever since that case, which was it was on his squame excision that we actually discovered that he had CLL. Ever since then, I've been particularly careful, and I've found a couple of cases where we found CLL in the background of the skin, from, in the background of a basal or squame, something like that, and that they didn't know the patient had it. So it's a common enough disease that it's out there, and if I see a dense infiltrate and they look very small and monotonous, you can't really see the cytology here, unfortunately, but they have these very uniform nuclei and supposedly kind of a soccer ball or a football, if you're watching this from another country aside from America, football pattern of chromatin, if you've got a good imagination maybe, but you definitely can't see it on this scan. So anyway, if I do think about that, what my panel is I usually do a CD3, CD20, and CD5. 3 will mark the T cells, 20 will mark the B cells, and 5 should only mark normally the T cells, not the B cells. But if I see a lot of B cells and they co-express CD5, then that's very worrisome for CLL. Then you can do additional markers to confirm it and do additional workup. But that's kind of the screening panel that I use when I suspect CLL in the background, if I see a dense infiltrate. So anyway, good to know. And not just in the background of squames. If I see that on other types of specimens too, and think about CLL, like, look, see, that's like more dense perivascular inflammation than you normally see. And it's way away from the tumor here. So it seems like it's something else going on, not tumor related. All right, guys. Okay. We'll get it right side up. All right, now this is a great example. What's this?
A regressing kerato. Oh, sorry, Kayla, if you want to go.
Yeah, a regressing keratoacanthoma. This is the time where I'm like, this is definitely a KA, okay? One, I can see the bottom. I can see what's happening underneath it because it's a nice deep shave. So as I've told you before, especially on extremities, when you're able to, the deeper a shave you can get on a keratinocytic or, scaly lesion where you're thinking about squame or actinic keratosis, the deeper a shave you can get, the more likely I am to be able to give you a definitive answer. It's the ones that are transected that I'm much more cautious about. But here, what we've got is this cup-shaped, keratin-filled kind of crater, but for one thing, it opens up broadly to the surface of the skin. It's got areas like this that are like multiple cups. This is too complex and complicated in shape to be like a regular cyst. We don't normally see wide, broad openings of cysts. Cysts open to the skin surface through a little narrow punctum usually, but especially on sun-damaged extremity skin of an older person with a broad opening cyst to the surface like that, that's a huge, big cup. That's almost certainly not a cyst, but is either going to be a keratoacanthoma or squamous cell carcinoma. And in this case, we've got very bland, glassy, not atypical at all. You would never look at this and even think it's a tumor. I could tell you this is kind of, epidermis that's got a little bit of atrophy or something, and you'd say, okay, sure, yeah, I could say this is epidermis with scar from a biopsy site, and you'd totally believe it up close. But at low power, clearly that's not what's going on, right? So this is what happens when keratoacanthomas begin to regress. The body's immune system kind of reacts against them. They often will get inflammation mixed underneath them. They begin to get really thin and atrophic, the lining cells. They begin to get very, very bland and eventually small and no atypia at all. They regain a granule layer oftentimes like that. And then you will usually see a band of scar underneath them. So that's kind of evidence the immune system attacked it, it started to go away, and then it's leaving scar tissue behind underneath it. So on ones like this, on this, I would just say this is a keratoacanthoma with features of regression. If I'm not certain, I might still hedge it if it's like a transected piece, or if sometimes these are really tiny, and I'll say, oh, it's suggestive of a keratoacanthoma. I believe lesions like this you could just leave alone and watch and wait clinically. And as long as it goes away, all should be well. If it grows back or something, then you need to go back and remove it, in my opinion. So that's a really, really nice example, though, of regressing keratoacanthoma, and it always is shocking, I think, to my trainees about like just how bland this looks and how this doesn't in any way look atypical at all, the lining of it when it starts to regress like this. Sorry, it's not coming to focus, but there. Really good example. Okay, now case 8, I think we're on. What's going on here?
Several different areas of interest.
Yeah, all right. What's this one?
Basal.
Yeah, basal cell carcinoma, kind of infiltrative, little, fingers of, thin cords stretching out with a lot of desmoplastic stroma. So I'd call that personally probably a little bit of infiltrative pattern at the edge. And there's some nice squamous metaplasia right there. Okay, that's one. So basal. And then next
Good
door,
old Seb.
what's this? Yep, good old Seb. And then, oh, wait a second. That's why we don't stop. Don't even stop at 2 diagnoses. Look at the whole thing and what's going on here.
Looks like melanoma in situ.
Yeah, this is melanoma in situ. Look at that. Melanocytes trickling along the basal layer here, and they're large and atypical. So this is like a trifecta. It's like a basal, seb, and melanoma in situ all together. So I always try to look carefully at the edges to make sure I'm not missing a sneaky background melanoma, even if I see an obvious basal or squame in the middle of the biopsy. So this is like lentigo maligna pattern, and in fact there's probably a little bit of like regression right here. This zone of fibrosis, I imagine, probably represents regression. So, pretty impressive. 3 for 1 diagnosis there. Okay, what's the next one here? What do you think about this from
shave here.
Low power?
There's some like basilar induction, more blue and strand-like, kind of some follicular induction. There's a lot of spindle cells in the superficial dermis there. That's good for the top of a dermatofibroma.
Yeah, good. The trick is that this can look like basal cell carcinoma. Usually it does not have clefting. That's one clue that can help me to tell that this is hair follicle. These are basically the roots of hair follicle that's growing here. And you can see it's even got like a little bit of a papillary mesenchymal body. And then this one's nice because it's even got those little bright red trichohyalin granules, right? So to show you, this really is a little immature hair follicle growing here. And then that can help you know that that's the same thing that's happening here. So I find that the stroma pushing right up against it and hugging it without that mucin-filled little space is a really helpful feature. Also, the presence of all these spindle cells in the dermis kind of swirling around and wrapping around little tiny bits of collagen is good. This is a dermatofibroma, and sometimes, as you guys know, dermatofibromas can induce the epidermis to grow. They either make the epidermis get acanthotic and hyperpigmented, or they can cause little hair follicles to grow that mimic basal cell carcinoma, or they can cause sebaceous glands to grow. They can induce all of those different things to grow. There's more of the DF right there. So if you think it's basal, but you start to see areas of acanthosis with kind of flattening or tabling of the reedy, then stop and ask yourself, oh, could this maybe be the top of a dermatofibroma? So that's a kind of useful clue. And it can be hard if it's transected, but finding the spindle cells and seeing it pressing right up against the basal are helpful feature, or the basaloid stuff is helpful feature for me to know that it's a benign basaloid follicular induction over a DF rather than basal cell carcinoma. And I have seen a couple times actually of true basal cell carcinoma growing right over or next to a dermatofibroma. But I would say that as a general rule, and certainly on an exam, if you think it's basal cell carcinoma plus dermatofibroma, the answer is just dermatofibroma with induction, not basal cell. In real life, it can occasionally happen, but it's still pretty rare. All right. What's this one?
Another clear cell Bowen's.
Yeah, this is also Bowen's disease and squamous cell carcinoma in situ, kind of like that one I showed at the beginning, although much more prominent vaculation here. And this is probably the total clearing of the cytoplasm is probably glycogen related, right? You can see again that nice eyeliner sign right there. And look, if you just had this, if you just had that, you could certainly wonder, could this be a really robust pagetoid melanoma or something? But once you see it filling the whole epidermis top to bottom, melanomas just don't do that, okay? I mean, like, I've seen only a few times where melanoma had areas of full thickness atypia in the epidermis, and those times, like where it was basically consuming kind of the epidermis, there was obvious melanoma back in the background and invasion and nesting and all the stuff that tells you it's melanoma clearly. Subtle melanoma in situ, in my experience, never going to do this. So once it's full thickness, I don't feel like I need immunostains here. This is, to me, clear-cut squamous cell carcinoma in situ with clear cell change. Here's an area that's less clear cell, atypical mitoses. And there it's kind of tangential here, cut at an angle. Again, look at, you can see the nice eyeliner sign right there. Perfect. So pagetoid, squamous cell carcinoma in situ / Bowen's disease with clear cell change. So sun-damaged scalp of an old person, I'll tell you that. Look at all that soil elastosis there. And there. But not here. What's your differential for something like this? This is a very hard case.
Sclerotic, and with the like confluence of melanocytes, that would put me into something like a melanoma, and then with what looks like sclerosis, like a desmoplastic melanoma.
Good, yeah. When you see a spindle cell proliferation with a lot of background collagen in the dermis on an older sun-damaged person, you always have to ask yourself, could this be desmoplastic melanoma? I mean, this could easily be scar, right? Scar could look just like this. Sometimes these can look very much like neurofibromas. So if I see that spindle cell in the dermis, even without much atypia, I start looking around closer to see, can I find some atypical cells? Can I find mitoses? And then do an S100 or a SOX10, because these are going to, desmoplastic melanomas only stain with S100 or SOX10. They don't stain with the other melanocytic markers, almost never. And look, here's a mitosis right there. So if you're lucky, you'll find a mite, but sometimes the mites are pretty sparse in these, and you're just looking for pleomorphism. But basically, if you're thinking of scar and there's not a good reason for the scar to be there and it's sun-damaged skin, especially on the head and neck of an older person, I usually will do an S100 or a SOX10 just to make sure. Now here, you're right that I think you probably are right that there is maybe a subtle melanoma in situ component up here. I honestly cannot tell for sure on this H&E. I would do a stain, but it feels like there's too many extra little cells with that little halo around them here. So probably that's melanoma in situ, but the important thing to remember is that desmoplastic melanomas about half the time don't have any identifiable in situ components. Whether because it regressed away or because they grow without one is debatable, but in any case, it's a well-known thing that a significant number of desmos don't have a melanoma in situ component. I've got a couple of videos about this on my YouTube channel. Here's another mite right there. The other important thing is the trick about pink collagen replacing blue elastosis. It only works for older sun-damaged people, but once someone gets severe solar elastosis, it should fill their dermis up at the top. It starts up here, right below the basement membrane, and pushes down, and then their new dermis becomes blue once they're old and sun damaged. So then if you get pink collagen replacing that and pushing down the elastosis, that means this is not the collagen they were born with. This is new collagen that was deposited once they got old and sun damaged. And therefore you have to go figure out, why is that collagen there? Is it a scar from a previous biopsy or trauma? Is it sclerosis or desmoplastic desmoplastic stromal response around the basal cell or some other invasive tumor? Is it a desmoplastic melanoma? Something is making this collagen. This is not the normal collagen. And in a sun-damaged person, new collagen deposition is often, or is it regression under a melanoma? That's the other thing. This could be a melanoma with regression. So a lot of times if I think there's extensive regression in a melanoma, I'm going to want to do S100 or SOX10 to make sure that that's really regression and not actually a subtle desmoplastic component. Because that would change basically melanoma in situ with regression versus what this is invasive melanoma, desmoplastic type, probably 5 millimeters deep. A lot of times at the time of diagnosis, these are 10 millimeters, 15 millimeters. I've seen them grow all the way down to the galea, right above the outer table of the skull. They tend to be late diagnosed because they often are scar-like and non-pigmented clinically, so they don't look very suspicious. This is a particularly subtle one because aside from those couple mitoses and a bit of hyperchromasia, really not terrible atypia here. I mean, that is a bit on the cellular side and the hyperchromatic side for a scar, but I got to tell you, I mean, I don't look at that and immediately think malignancy. I mean, I'm tuned in to always think of desmoplastic melanoma because I've seen them and they're very tricky. But I mean, if you just gave me that picture right there, I wouldn't say, oh, that's clearly desmo, that's clearly malignant. No, it's only when I see this whole picture that I think, ooh, wait, I got to rule out desmoplastic melanoma, and then I do the stains. Very, very tricky. And these are different from spindle cell melanoma, which basically is very cellular and looks ugly and like almost like a sarcoma. And there's some differences in behavior. And you can watch that other video to find out if you want. Okay.
So a little epidermal invagination with some villi and acantholysis. So looks like a cute little warty D.
Yeah, this is a warty dyskeratoma, and look, we always teach that they're cup-shaped and connect to the surface, and then they've got acantholysis and dyskeratosis, which we've talked about before. The cells are falling apart, getting pink and rounding up. Some of them are beginning to break down and turn like really dark and pycnotic. Their nuclei look almost like little rounded parakeratosis, is the way I think of it. Those are the corons, or the free-floating little long ones. Those are the grains. So acantholysis here, plus parakeratosis, or sorry, dyskeratosis here, then that goes into that group of diseases that can do that, which is warty dyskeratoma, Grover's disease, Derrier's disease, and some others. But in any case, warty dyskeratomas often are cup-shaped and connect to the surface, but I think, as I've told you guys before, cup-shaped things that invaginate from the surface, if you don't cut them and section them perfectly down the middle, they're going to actually look like a cyst. Right? So this looks like a cyst, but I bet you if you cut into this block enough, this thing will connect right up to the top out of the surface of a hair follicle. So just like a cyst does, right? Cysts connect to the surface too. If you cut deep enough, you'll usually find that little punctum. So remember that. Molluscum can do this. Warty dyskeratoma can do this. So if you see acantholysis and dyskeratosis in an apparent cyst, it's almost certainly actually a warty dyskeratoma that you just haven't sectioned through the middle of. So nice example of that.
So
all right.
Very basophilic specimen. From scan, it could be a BCC, common things being common. But getting closer, and even from scan, you can start to see that there's, some sort of vacuolated areas, and they kind of compress into the nucleus as well. So for this one, given the amount of basaloid cells and the degree of pleomorphism or atypia, I was thinking sebaceous carcinoma.
Yeah, very good. This is a nice example of sebaceous carcinoma. Now, I would say right here, the cells are very blue and basaloid, but not super ugly. If you just gave me this picture, I'd say, oh, this could potentially be a sebaceoma, right, which is a benign sebaceous tumor. And I've got videos about a variety of different sebaceous things, but that's why I'm always really cautious with sebaceous tumors, especially if I can't see the bottom, because sometimes sebaceous tumors are malignant by nature of their obvious pleomorphism and atypical mitoses, but other times they don't look super ugly, but it's their infiltrative growth that tells you, like in this case. Clearly, that is not growing like a benign thing. That's infiltrating, just like you said, from low power, you could certainly think of a kind of a nodular and infiltrative pattern basal cell carcinoma that's infiltrating down. But when you go closer, there's obvious vacuolated, multivacuolated cytoplasm with little indenting or scalloping of the nucleus. So clearly, I don't feel like you really need any stains here. I mean, it's obviously a sebaceous tumor, right? To me, that's obviously sebaceous. So I think that is a nice example of sebaceous carcinoma. And I always try to keep it in mind when I see something, particularly if I see an ugly carcinoma that overlaps between basal cell and squamous cell, always keep it in mind. This one, not so ugly, but infiltrative and has obvious sebaceous differentiation. And look at that, really infiltrating there. So, sebaceous carcinoma.
That one I like for infundibulocystic BTC. You can see kind of the pink strand and blue bud appearance.
Yeah, that's a good point. So it's a basaloid tumor, but it's got little cysts filled with keratin, and it's got this very funny kind of antler-like, staghorn, I don't know what name you like for it, pattern that instantly gives me the feeling of, oh, could this be a hair follicle tumor, right? These little nests that are branching out, and it doesn't have much in the way of mucin or clefting or that mucin-rich stroma. So I definitely would be thinking of a hair follicle tumor here. So I think you could think of this two ways. If I just see a small area that looks like this, like around a hair follicle, then I would usually call it a basaloid follicular hamartoma. But this one is pretty big and is infiltrating down. I mean, it's pushing down into skeletal muscle. Now, I know we're on the face here, but I mean, when I see that in an older sun-damaged person and it's pushing way down, I'm usually going to end up calling that basal cell carcinoma, or at least saying I'm suspicious. So when you see something that looks like that you decide is a basal cell carcinoma, but it really looks kind of follicular, some people call those infundibulocystic basal cell carcinoma, or you could say basal cell carcinoma with follicular differentiation. One thing that I will do sometimes in these, if I'm between the two, is do a cytokeratin 20, which in benign hair follicle proliferations, a lot of times you'll have scattered benign Merkel cells, like passenger Merkel cells dotted throughout the lesion. And in basal cell carcinomas, you tend to lose those. And there's a variety of other stains people have done to try to tell apart basal cell carcinoma from basaloid proliferations like benign hair follicle tumors, and I feel like a lot of those are kind of challenging to use, and the reason people have described so many is because none of them are totally perfect. But here, based on that infiltration down here and this pushing way down, I would say this is basal cell carcinoma, infundibulocystic type. A lot of times I just actually will call these nodular type in my pathology report in case the treating physician is not familiar with this term, infundibulocystic, which sounds a little bit more, kind of wordy, but doesn't, to me, these are basically like a low risk form of basal cell, just like a nodular type, not the aggressive type. All right, so that's a good example.
Yeah,
Okay,
so right at scan, it looks like we have some acanthosis, and when you go in closer, the cells are pretty nice and uniform. It's a clonal proliferation, but very bland looking cells. And you can see some cuticle-line ducts as well. Since this is mostly in the epidermis, that's good for a Hidroacanthoma simplex. But then down here, maybe getting a little deeper, some more like a poroma.
Yeah, exactly. And to me, poroma and Hidroacanthoma simplex are on a spectrum, and I think that spectrum also includes so-called dermal duct tumor, which not everyone agrees even exists, and hydradnoma. They're all part of the acrospiroma family, which is composed of kind of uniform cells with pink cytoplasm that look kind of squamoid, and then they have sweat duct formation. So this is a great example, actually. Yeah, if I just had this over here, I'd say, oh, it's poroma. This over here, I would say fits nice for Hidroacanthoma simplex. So let's look closer at this. At low power, I thought about seborrheic keratosis. If I first look at this, getting closer, I see, though, that there's clones, right? Individual islands of cells that look very uniform, and they look different, right? Look at that sharp cutoff. They look different from the rest. So then you could think of, is it a clonal seb? Is it a squamous cell carcinoma in situ, like that one we looked at earlier? But after looking closely at the cells, they look very uniform and very bland. So that would make me favor that it's benign. And over here, though, look. These, I mean, that could easily, I could show you a picture and tell you, oh, this is a clonal seborrheic keratosis. And you'd say, oh, yeah, sure. So I feel like there's a very close overlap. To me, the key to tell this apart, you can do some different stains, but the main thing I want to see is I want to find little holes that have pink cuticles, so ducts. And once I find duct formation, then I would say if it looks like a clonal seb, but it's got ducts in it, then it's probably Hidroacanthoma simplex. If it begins to push down and get finger-like growth down into the dermis, then I would call it poroma. So I think this is a really good example that shows kind of both the poroma-like areas and the Hidroacanthoma simplex-like areas. And here, the sweat duct differentiation can take a couple different forms. Sometimes it makes kind of cystic, dilated spaces with sweat secretion in the middle. Other times it's little tiny lumens like this. Let's see if that gets in focus, with a little droplet of inspissated or dried out sweat secretion in the middle. And I think the best ducts are down here. Here's some more of those kind of dilated, branchy looking ducts. And then these are the perfect, that's exactly what you want. This is what you should burn in your mind as. This is what sweat duct differentiation looks like usually in poroma and colleagues and related entities. Perfectly round, punched out little holes, lined by a dense pink lining that we call the cuticle, and often with little droplets of secretion in the lumen. And if you do a stain like CEA, carcinoembryonic antigen, it will often highlight the lumen there. Sometimes I will do that if I'm having trouble finding ducts, although I've found that stains don't work spectacularly on these. So over the years, I've done it off and on, and in the end, I usually just kind of make a decision on H&E a lot of times. Every once in a while I'll try it, but nice ductal differentiation here. So poroma here, in my opinion, and then Hidroacanthoma simplex. And the thing that poroma and Hidroacanthoma simplex both share is this, the sharp cutoff between the edge of the tumor cells and the adjacent epidermis, right? A few things do this. One of the other things that does it is clear cell acanthoma, right? So I think sometimes I'll think about, could it be poroma or Hidroacanthoma simplex? Could it be clonal seb? Could it be clear cell acanthoma? If I just see this edge, obviously looking at the whole lesion here, I would not think about clear cell acanthoma, but that sharp delineation between tumor cells and adjacent normal epidermis, I think a very, very helpful clue for the diagnosis of poroma or Hidroacanthoma simplex. So that is a really beautiful example of this entity. I rarely ever see Hidroacanthoma simplex. I see poromas, but pretty rare to see poroma that's only in the epidermis, at least in my experience. So this is a good one.
So in this one in the dermis, we have these basaloid islands with a lot of clear spaces, kind of pseudoglandular, full of mucin. This looks like a basal cell carcinoma, but the adenoid cystic subtype with those pools of mucin there.
Yeah, so I would call this is an adenoid subtype of basal cell, right? And the big concern is that you could confuse it with adenoid cystic carcinoma, which is a salivary gland carcinoma that often arises like in the parotid and invades the nerves and can be locally pretty aggressive and bad. It rarely can occur as a skin primary, and it seems to be much more indolent in the skin. But I would want complete excision for a true adenoid cystic, whereas basal cell, sometimes you just do curettage, right? And you can manage more conservatively depending on the situation. So I don't actually have a good adenoid cystic to show you, but in true adenoid cystic, these little blue mucin-filled pools are very sharply rounded and circumscribed. And there are some other features and some stains that can tell it apart. Like I believe adenoid cystics are usually SOX10 positive, even though they're not melanocytic. There are some sweat gland and salivary gland tumors that stain with SOX10. I believe c-KIT, CD117 is positive. All right, so, but the thing that helps me is basal cell carcinoma with adenoid change, what we're seeing here, is really common. Like I see it multiple times per week, you know. When it's really extensive, occasionally it can confuse people and make them think about a salivary gland tumor like adenoid cystic, or to think about like a metastatic adenocarcinoma. So the key to me is ignore the mucin-filled pools and look at the other islands and see if you can find features of obvious basal cell. Like look, mucin-rich stroma and a little bit of a cleft with mucin in it between the tumor cells and the dermis, and basaloid palisading around the periphery. So once I find other features that look like classic slam dunk basal cell carcinoma, then these big mucin-filled pools are no problem at all. This is just adenoid change, and in fact, when I report this, I just say basal cell carcinoma, comma, nodular type. I don't even mention the adenoid because it's going to confuse people potentially and make them worry this is something bad, and it's not. It's just a subtype, and usually you see it in the nodular type, although it's possible to have also infiltrative or other components of the basal. But I find that this one's pretty extensive, but usually if you look around, you'll find other areas that don't have the adenoid change. like here, that look just like, or very little of the adenoid change, but look at that cleft in the mucin. This looks just like regular basal cell carcinoma. So I find that a helpful clue with all the different weird variations of basal cell that exist. Clear cell, granular cell, pleomorphic, all these different weird variations that don't have clinical significance, but that can confuse us microscopically. Look around and try to find other areas that look like good classic basal cell. It will make it easier to diagnose the weird areas, I feel like. So, and oh yeah, I forgot the main point is I forgot that in adenoid basal cell carcinoma, the mucin pools are very irregular and unusual shapes rather than the perfectly round punched out little circles that you see in true adenoid cystic carcinoma. Basal cell carcinoma with adenoid change has these very irregular, loose, kind of, meandering pools full of mucin. They're just very weird, unusual shapes, most of them. Sometimes they can get more rounded, but usually you'll get these big, irregular ones, and that's not typical of adenoid cystic carcinoma in my experience, but fits nicely for adenoid basal cell carcinoma. All right, so here for contrast is an example of a true primary cutaneous adenoid cystic carcinoma, and there's a lot of different patterns going on here. You can see there's some little tiny islands, some big islands. Some of the areas have that irregular kind of blue mucin-filled space like we saw in the adenoid basal cell carcinoma. And I think, to me, the most characteristic areas are areas like this. And these are the very punched out kind of cookie cutter or cribriform kind of pattern of multiple small, very regular, sharply circumscribed holes that are punched into the middle of the basaloid appearing tumor islands. And you can see you don't have as much of the palisading with mucin-rich stroma and clefting. Stroma looks different than a basal cell. And then, like I said, you can use some immunostains to help sort it out further in difficult situations. But I think with practice, they look quite a bit different most of the time. So this is what I think of as kind of a characteristic example of a true adenoid cystic carcinoma. And I'll put a link to this whole slide image down below so you can check it out yourself.
So this one looks like maybe scalp, like head, neck. And
yeah, good. Big
yeah,
hairs.
you've kind of got this like broad, bald,
Then
bumpy, and bubbly area. So good for Nevus sebaceous.
Nice. Yeah. Yeah, Nevus sebaceous, like you said, bald, I think is really helpful. When I see a big excision of this and suddenly I'm on the scalp of a young person and I've got big anagen hairs and then they're gone, and then on the other side of the lesion I see them again, that's Nevus sebaceous usually, because Nevus sebaceous usually lacks big hair follicles and instead has big sebaceous glands. Depending on how old the patient is, younger patients, the sebaceous glands are small and immature. As the patient gets older and goes through puberty, they have androgens that then allow the sebaceous glands to expand and make more lipid. Sebaceous glands are big. They connect straight up to the surface, like so. Oftentimes you have epidermal acanthosis that resembles a wart, a verruca, or seborrheic keratosis, although sometimes you don't. Like, look, this is not very dramatic. I mean, really almost normal epidermis, except maybe a little loss of the rete. And then look, we've got some basaloid stuff here. So you can get a variety of basaloid things. Some of it's hair follicle, like induction-like change. Some of it's true hair follicle tumors, like tricholemoma, trichoepithelioma, trichoblastoma. You can see all sorts of benign hair follicle tumors and some sweat gland tumors like syringocystadenoma papilliferum. I've got videos about all those things on my channel. All that stuff tends to occur and arise within Nevus sebaceous. So I think it's a nice, like, kind of, it's like fertile soil for growing all of these unusual adnexal tumors. And very, very rarely you can see true malignancies like true basal cell carcinoma or apocrine carcinoma in a Nevus sebaceous. But in my experience, that's quite rare. The vast majority of times when I see a tumor growing in a Nevus sebaceous, it ends up being a benign adnexal tumor. And look, here, that looks very basaloid. It's got palisading, but what's that? It's a papillary mesenchymal body. So whether you call this an immature hair follicle, like induction, or a tiny little bit of, beginning trichoepithelium, it doesn't matter. Benign adnexal, right? I've even signed some of them out, like if it was for a non-dermatologist, I would say Nevus sebaceous with a variety of benign adnexal tumors. And also the other clue for Nevus sebaceous is usually you'll find, or not usually, sometimes you will find apocrine glands or eccrine glands that begin to look apocrine and have larger round nuclei with central prominent nucleoli, so-called apoecrine glands. So apocrine glands or eccrine glands that look apocrine in the dermis is another really good clue for nevus sebaceous, because you're not supposed to have apocrine glands on your scalp normally. And remember, these are hamartomas that grow unusual adnexal structures that are disorganized. So nevus by the word meaning birthmark in Latin, not meaning melanocyte, even though in modern usage we use it in dermpath to mostly refer to melanocytic things. This is one of the non-melanocytic nevi, and that's because it's a birthmark, not actually a melanocytic lesion. All right, let's, ooh.
Thought at high power this was good for a granular cell tumor.
Oh, good. But gosh, that looks like squamous cell carcinoma, doesn't it? So scary. But like you said, there's other stuff in the background. So from low power, this looks classic for granular cell tumor, pale cells filling up the dermis and very helpfully trickling between the collagen. I find that the low power clue, pale cells filling dermis and oozing between and intercalating or trickling between the reticulodermal collagen, looking kind of infiltrative looking, although that name sounds scary, so I don't usually use that, but that's basically what it looks like. But the collagen doesn't seem to mind. There's no like fibrosis or host response here. And this is a very typical characteristic pattern of granular cell tumor is they trickle between collagen. They have the granular cytoplasm because they're filled with phagolysosomes, and these blobs, which people call pustulo-ovoid bodies of Million, and they stain with S100 and CD68 and PAS, which you don't really usually need to do. But the thing to remember is that sometimes, oh, and there, that's nice, look. Perineural involvement. Oh, I thought it was a nerve, I was wrong. But they usually do. If you look around, like almost 90% of them will have tumor wrapping around nerves. Totally a normal benign finding that is present in the majority of granular cell tumors. Not worrisome at all. All right? So look, the thing here though is, how do you explain the epidermis? Is this like a coexistent squame? Okay, if it loads here. What's going on here? I mean, that's not granular cell tumor, is it? There's granular cell tumor in the background, but what's happening with the squamous stuff? So this is pseudoepitheliomatous hyperplasia, reactive epidermal hyperplasia, and granular cell tumors tend to incite this and make the epidermis grow like this, just like we can see over like invasive fungal infections sometimes, or in bromoderma, halogenodermas, right? All these things that mimic squame but are actually benign and reactive. Granular cell tumor is notorious for doing this. I feel like the times you see it most is in mucosal sites, like on the tongue, which is really dangerous because if you call it squamous cell carcinoma on the tongue, someone's going to probably get a hemiglossectomy or something, and then when you find out later, oh, whoops, it's actually granular cell tumor, that's not great. So always, I think it's a good rule, especially in the tongue, if you're a pathologist watching this, you know, you think you see a squame that's kind of bland looking, look in between the islands of keratinocytes and make sure that you don't see any granular cells in there. And if you do, then you got to really think maybe you're dealing with a granular cell tumor and mimicking a squame. And in the skin, you can sometimes see it. So it's this kind of pseudoepitheliomatous hyperplasia. I've also seen a case like on the foot that was mimicking a wart. It looked like a wart, and then on a deeper biopsy, granular cell tumor. So it can make the epidermis grow in weird, strange ways and develop some glassy atypia. All right, 18. It's a challenging case. So we got stuff down here, but we'll look at the top first and see what's going on. Where do you think we are in the body?
Maybe like a
you can tell
feel-good
without
spot.
being told. Feel-good spot, right. This could be the genitals, or it could be the nipple, because we've got bundles of smooth muscle. In the nipple, I feel like the bundles of smooth muscle are really big and large, and in the labia or the scrotum, the genital skin, they're usually many of them, and very, very small bundles. So there's way too many smooth muscle bundles for normal dermis, plus apocrine glands. So yeah, this is genital skin, although you can see apocrine glands around the nipple too, so nipple would be fair thought. But I'll tell you, this is genital skin. And we can tell it probably is because of the diagnosis here. So what would you call if you just
Like
had
condyloma.
this? Yeah, it's a polypoid growth with, instead of the pointed finger-like projections of a regular verruca or wart, genital warts, condylomas, have this rounded knuckles, right? Like if you ball up your fist and make knuckles, and that's a pretty helpful clue. And then I want to go and find coilocytes. And here I think we've got nice coilocytes. Not just are they vacuolated, but they have large nuclei. So as you get towards the granular layer, normally the nuclei get smaller, but here they get paradoxically larger and then get this paler, clear cytoplasm around them. So to me, that's viral cytopathic effect from HPV. And we've got this lobulated proliferation that's kind of knuckled condyloma. But then underneath here, well, I don't know, but that's not condyloma here. What is going on? We've got this cystic, invaginated growth pushing way, way down deep into the tissue with kind of cystic change in the middle. Up close, it's bland and glassy pretty much. So this is an area of debate and very frustrating nomenclature issues throughout the history of pathology. In the past, people have called things like this verrucous carcinoma, which has sometimes also been equated with the giant condyloma of Lowenstein and Buschke, right? I think is the old school eponym name for it, okay? In more recent times, based on my understanding, and there's a really good paper about anogenital squamous proliferations by Mei Chan in Archives of Pathology, July or August 2019, my colleagues and I, Jennifer Cayley and Sarah Shalin and I put together, we were editors on a special issue of Dermatopathology for general pathologists. And so that's all in 2 issues of Archives in the summer of 2019. I'll put links in below if you're watching this online. Mei Chan wrote just a beautiful paper explaining and simplifying these very complicated lesions with complicated naming. So my current understanding is that verrucous carcinoma is now considered to be a tumor that is bland, glassy, warty looking on top and pushes down into the dermis like this one's doing, but it is not HPV driven, so it does not have coilocytes. So to me, this is not a true verrucous carcinoma here. This is probably either you could think it's a giant condyloma, like a true HPV-driven condyloma, but I don't think so because look at how deep that pushes in. I think it has to be malignant. So I think this is a squamous cell carcinoma, kind of the warty HPV-driven type that's very well differentiated, pushing down and invading. So I would not call this verrucous carcinoma personally. I would call this an invasive squamous cell carcinoma. And there's some different subtypes that the gynecologic pathologists give to these, whether it's keratinizing or basaloid or warty. But in any case, a true verrucous carcinoma, sometimes it's seen in the genitals, sometimes in the oral cavity. The place I most often see it is actually on the sole of the foot. But those are very warty-like, but they don't have HPV, is the current thinking. Again, there's a lot of controversy and a lot of confusion in the literature about this entity over time. So to me, I would say this is an HPV-driven squamous cell carcinoma arising from condyloma.
So with giant condyloma, they can push down, is what you're saying, as a verrucous carcinoma?
So the problem is that because giant condylomas get so big, it can become very hard to tell what areas are kind of invagination within the condyloma versus pushing invasion. On this case here, I think this is true pushing invasion. I mean, look at this. Doesn't look like we're in the middle of a big polyp. There's a little polyp here, but there's this huge crater going way down. So to me, I would certainly, if I had this case in real life, I would show my gynecologic colleagues, my gynepath colleagues. I think is so helpful when you deal with vulvar or anogenital skin lesions, especially squamous atypia and HPV things. I feel like GYN pathologists are very familiar with the complexities of this area and the terminology, because a lot of times these are going to get treated not by derm, but by gynecologic oncologists. And so it's really important to use the proper terminology that's going to be understood by the treating physician. I mean, that goes for anything in dermpath. Anytime I'm near an orifice, right? Anogenital, near the oral cavity or in the mouth, or near the eyes, I want to make sure I'm using terms that are going to be understood by ENT, ophthalmology, GI surgery, gynecologic surgery, urology. So I think that's a general rule. But no, to me, I think this is way too much for just a condyloma, even a giant condyloma. To me, this is pushing invasion of the dermis. This is cancer. So that's my thought. But it can be really hard to tell when they're polypoid and complex, like what's pushing invasion versus what's just the middle of the polypoid, fungating looking condyloma. And those can be really challenging cases.
Really dense dermal tumor here, spindle cells kind of abutting the epidermis, even creating a little separation of the epi. I can't really tell just looking at these cells what they are, but I think this brings up the SLAM, like spindle cell differential, squame, AFX, desmoplastic melanoma, leiomyosarc. I'd even throw in maybe like a weird vascular tumor here, just because I really can't tell like what these.
Yeah, right. Every once in a while, you can get solid spindled angiosarcoma. So yeah, the SLAM differential, like you said, spindle squame, leiomyosarcoma. They usually don't. They usually look like leiomyosarcomas, but spindle cell melanoma, angiosarcoma, and others, right? And then, of course, if you rule out all those, atypical fibroxanthoma / pleomorphic dermal sarcoma, which to me are the same tumor. We just give them a different name. If they are big, larger than I think 2 centimeters, have necrosis, perineural invasion, or invade the subcutis, then we call them pleomorphic dermal sarcoma because they have a tendency to be more aggressive when they have those features. If they're small and limited to the dermis, then we call them atypical fibroxanthoma or AFX. I've got some videos about this on my channel if you want more, but my general stain panel that I do, I feel like I can't tell what these cells are either. So I, even as a soft tissue pathologist, so I have to do stains. I usually use P63 or P40. Some people don't like that stain, but I like it. And then you can use various keratins. I'm tending to like cytokeratin 5/6, high molecular weight, seems to work the best for me. And then I'll do an S100 or a SOX to rule out melanoma. The P63, P40, and keratin was to rule out squame. And then I usually add a Desmond because I've rarely seen rhabdos in the skin, and that will also cover leiomyosarcoma. And I don't really do actin here because it'll stain, it can stain most of those things. And then also I usually will do also an ERG or a CD31 to make sure that it's not an angiosarc, although that's very rare. I have seen some that mimic the AFX. ERG does sometimes show patchy moderate staining in AFX, and I just ignore that. For an angiosarc, it should be as strong as the background vessels and diffusely positive. At least every angiosarc I've ever seen. So this ended up being negative on all those. And some people like to do CD10 and, you know, Vimentin and CD68. If you want it to turn brown, you can do one of those markers, but I feel like they're totally non-specific. I don't ever use CD10 personally for spindle cell tumors, or almost never, I would say. Yeah, I basically do those. And if it's shaved at the top, you have to say, well, it could be AFX or PDS. We can't tell unless we can see how deep it goes. This one looks like it's confined to the dermis probably. Still needs to be excised. But here I can't tell. I would still hedge on that and say, until the whole thing's out, I need to see it. And I always add a comment too, if it goes to Mohs, which a lot of times they do, please save the debulk specimen so it can be examined to see if there's deeper invasion.
This one, I was a little bit caught between a couple diagnoses. It doesn't mature terribly well as we go from the basilar layer superior in the epidermis, and the cells are large, but there's no, at least there's not like obvious parakeratosis. Like I can see a tiny little focus of it there. It's just such poor maturation, you know, so Bowen's obviously being the other one, the differential.
Yeah, right. This is a really hard case. And the pigment, of course, a distractor. Those are all just pigment keratinocytes, as you recognize, nothing to do with melanocytic. To me, I would look at this and think this is probably a really subtle Bowen's disease squamous cell carcinoma in situ, because I've seen ones like this that had obvious areas of malignancy and other areas that were very subtle. In the study set, this is called large cell acanthoma with Bowen's disease, which I think is totally fair and reasonable. There's, look, a high level atypical mitosis. There's a mite here. Sometimes squames and sometimes even actinic keratosis does not have para, even though we teach that they usually do, not always. Here, these areas look more atypical. So I think that's why this was called large cell acanthoma plus Bowen's disease. And I think that's a totally reasonable thing. These are ones sometimes we're doing the immunostains will actually help if you need. But here, look at that. Atypical mite, it's like a stick figure. It's like a guy on skis or something. I don't know. And it's way up here. So yeah, I would call this squamous in situ personally. I think it's totally reasonable to think it may be arising in a large cell acanthoma, which if you're watching this and don't know what that is, I basically think of large cell acanthoma as either solar lentigo or flat seborrheic keratosis with large keratinocytes. That's the way I conceptually think of it.
Bowen's versus melanoma, in situ versus Paget.
Oh, yeah.
Nipple or genital site makes me favor Paget's. Really good kind of spitting into the stratum corneum as well.
Yeah. And here it's pretty subtle, but you can begin to see ones that have little blobs of mucin. So you can do stains like mucin carmine to highlight that if you want, but they're basically trying to form little tiny ducts. and secrete some mucin. So that's a good clue sometimes if you can find those little ducts, or sometimes they'll even cluster together and actually make ducts inside the epidermis, like maybe it's trying to do that here. So yeah, this is Paget's disease, which I've talked to you guys about before. Cytokeratin 7 is usually my favorite stain for that, although there are some other complexities depending on the site and stuff like that. Paget's disease, and I think this one actually had focal invasion. Oh, there. That's suspicious, at least. I mean, that could connect, but I start seeing little buds going down. I want to look carefully to make sure there's not invasion, because Paget's can, like extramammary Paget's in the genitals, can sometimes invade and can sometimes behave more aggressively when it invades. So it's worth keeping an eye out for. And of course, in the nipple, it's underlying breast cancer until proven otherwise, because the majority of cases have underlying breast cancer of Paget's in the nipple. This is a nice example of infiltrative basal. If you like, you could call this micronodular, because it's got the little tiny round islands. I don't just want tiny islands for micronodular. I want them to be trickling out into the dermis away from the main tumor. That, for me, that's what I like for micronodule. Look, we're like getting way out here and it's trickling along. And when I see tumor-nescent basal going way out around in certain areas, the next thing I go do is look for perineural invasion. Because I saw this and I was like, I bet there's perineural. And look, here's a nerve, tumor very close, not in it, but it's really close. And then I did find one right over. I looked last night. Oh, I promise. I found it and I was like, oh, I can find that again tomorrow. There's no way to dot this or mark it, but there was a nerve involved over on this side somewhere. So in any case, oh, it was going to be so impressive when I showed you guys, and you're going to be like, wow. I'm just joking. I knew that wouldn't happen. But when I see a tongue of tumor, for any carcinoma, going out away from the rest of the tumor, always go look closely for perineural. In basals, it's not as significant. Oftentimes, they're harder to clear, though, and they take more layers on those. Micronodular basal. All right, what do we have, like 10 more to go? My gosh. Okay, I'm just going to go through them quick, guys. I'm sorry. They're going to fire me if I keep making you guys late to clinic every Friday. Okay, look, pseudoepitheliomatous hyperplasia looks almost like squamous cell carcinoma, but it's got little pockets of neutrophils. So PEH plus pus, infection till proven otherwise, right? And when we look closer here, we don't even have to do the special stain, because we can see the pigmented round fungal structures inside the giant cells. They can be in the dermis or floating in the epidermis. These are dermatiaceous pigmented fungi, black molds from the environment. And so when they make these round structures, medlar bodies or copper pennies, we call it chromoblastomycosis. When they make hyphae, we call it pheohyphomycosis. And those are just descriptive names, not fungal species. If you really want to know the species, you got to either do culture or molecular to figure it out. And here, this thing looks kind of almost like a polypoid seborrheic keratosis. But when we go closer, ooh, very blue, basaloid, atypical cells, lots of mitoses in here. And this is in the genitals. So this looks like a condyloma almost, but it's got full thickness atypia. It's got some areas that look like they might be coilocytes. And if you did a high-risk HPV, oh, look, there's like X marks the spot. There's 2 or 3 X mitoses right here, way up near the granular layer. So this could be a condyloma with high-grade squamous intraepithelial lesion, HSIL, which is basically like high-grade dysplasia or squamous cell carcinoma. In situ, to me, those terms are all synonymous in the anogenital area, and it's driven by high-risk HPV. But we call it HSIL because sometimes it's doesn't clinically fit for squame, and it's actually multiple lesions that are pigmented and fit better clinically for Bowenoid papulosis, which is actually what this is labeled as, is Bowenoid papulosis. But so there's no way to totally tell without the clinical. In any case, so it's high-grade dysplasia driven by high-risk HPV. So if I saw this, I would actually call it condyloma, probably because of its polypoid shape. I'd say this is condyloma with HSIL, high-grade squamous intraepithelial lesion. And when I'm signing reports for dermatologists, I add a comment to explain, because not everyone's familiar with that terminology. It's GYN pathology term. I said this is the term that is for high-grade dysplasia that's HPV-driven in the anogenital region. It encompasses Bowenoid papulosis and squamous cell carcinoma in situ. And here we've got a little proliferation of round ducts, some of which have little tails like a little tadpole or paisley tie. So this is the Paisley-Tie differential. And this with the obvious ducts here, this is syringoma. And they have very clear glycogenated cytoplasm, so clear cell syringoma. Note the collagen here in the normal dermis, very different from here. This very dense sclerotic collagen in the background is very characteristic of syringomas. And clear cell syringoma supposedly is more commonly seen in diabetic patients. Blue and basaloid, but it's got nice fibrous stroma closely hugging the nest without nice mucin-filled clefts. And we've got little round to ovoid stromal cells pushing in and invaginating into the middle of these nests. So those are papillary mesenchymal bodies right there. So you could either call this trichoepithelioma or trichoblastoma, whichever you prefer. Personally, I'd probably call it trichoep. I think it's labeled as trichoblastoma in the study set. To me, they are two ends of the same spectrum. The stroma and the papillary mesenchymal bodies are the key to distinguishing it from basal cell carcinoma. And this is a little focus of adenoid basal cell carcinoma in a little polyp, a little skin tag-like polyp. So this looked like a tag clinically, but this patient had Gorlin syndrome. So as you guys well know, Gorlin syndrome patients, basal cell carcinoma, basal cell Nevus syndrome, which has nothing to do with nevi. They develop basal cells, right, because of patch gene mutations. They get all sorts of unusual little basal cells, and sometimes they'll look like nothing clinically, and then on biopsy they'll be basal cell. So pretty unfortunate disease. It's very frustrating and problematic because these people get basal cells at a very young age. And this one's a pigmented basal cell. And this one is, the dermis is filled with tumor that's invading between the collagen. And we go closer, there's spindle cells making fascicles, and they have pink cytoplasm. Actin and Desmond would be positive, although actin is not specific. I don't really like that much for this because it stains lots of stuff, and there's atypical cells. So this is a leiomyosarcoma of the dermis, pilar type. Just like pilar leiomyomas, leiomyosarcoma of the dermis infiltrates between collagen. It should not be smooth and circumscribed. If it is in the dermis, then you have to rule out metastasis because leiomyosarcoma is from internal organs like the uterus or the retroperitoneal blood vessels. They can metastasize the skin sometimes. Sarcomas rarely metastasize the skin, but when they do, leiomyosarcoma is the most common one to do so. When they're confined to the dermis, though, primary leiomyosarcoma of the skin that's in the dermis has a very good prognosis, essentially, basically zero risk of metastasis from what's been reported. So some people say we should not even call these leiomyosarc, we should call them atypical intradermal smooth muscle neoplasm. Whatever name you do, I do usually add a comment to the treating physician that these are very, very indolent. They need to be excised, but the prognosis is excellent. And it's important you tell the patient that because if they go Google leiomyosarcoma, everything they find on the internet is going to be about uterine leiomyosarcoma, which is much more common than these skin ones, and they're going to freak out because it's much more serious disease. So remember, tell your patients that. And there's pagetoid pale cells here, but they're not filling the whole epidermis like we saw with the squamous cell carcinoma. And they've got a little bit of light brown pigment. So this is an example of pagetoid spread of melanocytes. So this is melanoma in situ. And it's important to remember that this can mimic squame and Paget's disease, of course. So immunostains can help you sort that out if you need. But here I think it's pretty straightforward to me that these are melanocytes. This is a rare entity here. We've got basaloid nests, look kind of like basal cell carcinoma, but no clefting, except down here, which is artifact and a little lymphatic. But look, each of these nests, look like they're filled up with other cells. See, this nest is like got a bunch of lymphocytes and maybe histiocytes in the middle. And if you do a stain, like for keratin, it will stain some of the cells, but a lot of these cells in the middle will be negative. So these nests are stuffed with a filling of lymphs and histiocytes and look basaloid. So this is called a, what does anyone know? Yeah, lymphadenoma. Oh, there, that's the better side right there. Perfect. They're stuffed like cannolis, right? Like those little Italian desserts, the crunchy shell and the smooth, creamy filling right there. So these are benign and beautiful, very rare. Cutaneous lymphadenoma, some people also call them adamantinoid trichoblastoma, although they look quite different from trichoblastoma to me. But that's a really, really nice example of the stuffed nests. Awesome. And this is a squamous cell carcinoma that's invasive. And down here, the cells are falling apart and rounding up. So this is the acantholytic pattern of squame. There's been debate over the years about whether it's more aggressive or not. Some recent papers have said it's not, even though the past people said it was. In any case, it does look weird, and I feel like it sometimes can be tricky if you're not familiar with it. It can have areas that can look like gland formation or even like vascular channel formation. The key is finding these rounded cells floating in the midst of the spaces, these rounded up atypical keratinocytes. So that's a nice example of acantholytic squamous cell carcinoma. And this, oh, here we go. This is similar to what we looked at earlier. It's got these kind of rounded nests, kind of like that first case I showed you of the kind of clonal looking Bowen's disease or squamous situ, but these are very bland, and in the background things look very much like a seborrheic keratosis. So this is a clonal seborrheic keratosis. Usually it's easy to recognize it, but sometimes the clones look very striking and very discrete, like these little nodules look very cut off from the rest and give you right away that feeling of like, ooh, squamous situ, and get you worried. So they can be really sharply demarcated. But most of the time, if you look around, you'll find other areas that look like obvious seb. If you need, you can try stains, but usually I feel like you just got to look on H&E and decide if it's atypical or not. To me, though, this is a nice example, very bland, and this is clonal seborrheic keratosis, kind of a flat seborrheic keratosis in this case. Good entity to be familiar with. We see this regularly. And this is a big, nasty invasive carcinoma. And when you go closer, the tumor cells are very ugly. They've got big, huge nuclei with washed out pale chromatin and large, prominent central nucleoli. And then there's lymphocytes everywhere surrounding the nest of tumor and infiltrating into the nest of tumor. So this is an example. Oh, and there are a lot of plasma cells in this one. This is a rare bird in the skin. So this is lymphoepithelioma-like carcinoma, and that's because it's kind of similar in pattern to what used to be called basically nasopharyngeal carcinomas, which used to be referred to as lymphoepithelioma. And in the nasal cavity, things like this are, in certain populations, are Epstein-Barr virus driven. In the skin, that is not the case as far as I understand. But lymphocytes surrounding the nests and infiltrating the nests. But here we've got lymphocytes infiltrating, peppering into the nests of tumor cells, right? Like from low power, this thing is like basically an ugly, poorly differentiated carcinoma swimming in a sea of lymphocytes, right? I also feel like the cytology of these cells has a very characteristic look that's different from most squames. All right, and then I think the final one, pus and crust on the surface. Epidermis looks like it's kind of proliferating. It's very jagged. It's entrapping elastic fibers down here. You guys who have been on Dermapath have seen this many times. You don't want to confuse this with infiltrative or invasive carcinoma because this is just reactive squamous epithelial reactive changes or pseudoepitheliomatous hyperplasia at a biopsy site. And we can tell it's biopsy site because we've got burned calcified collagen there and we've got grainy looking granular histiocytes. That's the aluminum chloride effect from the aluminum chloride dry sol hemostatic agent you guys apply after doing a shave biopsy. It tends to burn and calcify collagen fibers and leave these little, much more commonly you see these granular bluish gray or purple histiocytes, which is the clue that even without the history I know this has been biopsied before. And this stuff is all reactive. So study biopsy sites when you know it's a melanoma excision. Look at how weird the squamous epithelium can get when you know it's not squame. Like in a biopsy of a non-squamous lesion, you can get used to how weird the epidermis looks when it's reactive. And then when you're struggling with the case and wondering, is this reactive versus squame, it'll help you. So studying reactive changes is a really crucial skill for all pathologists in every body site because reactive changes can be really hard to distinguish from tumor sometimes. That's more of that aluminum chloride effect. All right, guys. Apologies to your attendings for me making you late once again. And have a great weekend.